Hi, I'm Dr. Denise Miller. I am an optometrist, as Christine mentioned. I work in Little Falls at Vision Sense Optical, and I have been there for about 6 years, a little over, and I've been in practice for 16 years. I always kind of feel like I should be able to do the math on that because I graduated in 2002, but it doesn't seem like 16 years have gone by. I am an optometrist who I do regular eye exams, regular meaning things that we're going to talk about today, contacts, glasses, and other eye conditions. But I also have a specialty, and I really don't even know what my title is anymore. With that, I look at vision as we see with the brain. And a lot of times we kind of forget that the eyes are just little antenna for the information, and if your eyes are seeing good detail and your eyes are healthy, that's all of vision. But it is really so much more because it takes place in the brain. So if I have any time at the end, I have kind of the typical eye conditions that are, and common eye conditions that are experienced as we age here set up, but if we have time at the end, I might touch on the neuro aspect. My title anymore is maybe a neuro rehab behavioral optometrist. So thanks for coming out. That is my contact information. We'll get started. So common visual anomalies or conditions that can happen really at any age, but certainly a little bit more common as we get older are listed. And I'll go through each one of those individually, but just to kind of give you a preview on what we will be talking about. Macular degeneration, also known as age-related macular degeneration. So we abbreviate it AMD, so if you see that abbreviation, that's what that stands for typically. Cataracts, glaucoma, dry eye syndrome, and then I just put on there some retinal conditions too. The high blood pressure and diabetes certainly are the most common reasons that you can have changes to your retina. So that's why I put those up, but there are other systemic or other health conditions that can contribute to overall eye health. Those are just the most common. And really, I should say too, if you have questions along the way, just shout them out. I have some time at the end for questions, but I usually function a little bit better if you have something you want to ask, just go ahead and ask. And I'll try to keep it short. I usually give a 10-minute answer. And we'll come back around and get back on track. So AMD, macular degeneration. The retina, so we'll go forward. I was kind of having a little bit of indecision on what slide to put first. But the retina is the lining on the inside. Is there a pointer? Oh yeah, okay. So the retina lines the inside of the eye, and basically it is a neurological layer. It's a direct extension of the brain. So as the optic nerve fibers come in from the brain, they branch out to make up the retina. So it's the lining on the inside of the eye. Okay. The macula is the part of the retina that gives you your center vision and your detail. The macula takes up just a little area here. So there's a lot of retina that is more designed to detect motion and is better in the dark. The macula is the part of the retina, again, center, detail, color. There's not a lot of area that takes up, and as you go away from the macula, the retina isn't set up, so the cells aren't designated for that detail. So when the macula is damaged, there isn't a lot of potential for good detail aside from that central point. So when you turn your eyes to look at something, you use your macula to do it. The rest of the retina gives you your side vision. So I kind of think about, sometimes the eye is kind of compared to a camera. And back when we had film in our cameras, the retina is kind of like the film in the camera. And so the reason macular degeneration is so significant is, again, it's the center, it's the detail. And if you think about the eye as a camera, even if you have the best camera and the best focus and you have poor film, your picture isn't going to be very clear. So that's what happens with macular degeneration. In the early stages, sometimes glasses can help somewhat, but again, because if we go back to this slide, We have to look at the whole eye as a system. And so even if this part of the eye is healthy and the macula and the retina is not, then you're not getting as good of detail. There are two forms of macular degeneration. One form is called the dry form. The other is the wet. And the difference between the two are listed, differences are listed. Dry macular degeneration is typically more common. It's typically a slower progression, so you might have some changes that I might see when I look, but the individual does not notice yet. It is, usually there are some little deposits, and I have a picture coming up here that will, it's not really like calcium, it's just a different composition. But they deposit in the retina at the macula, and there can be some pigment changes too. And so what that does is just gradually declines the ability to see good detail, affects the film in your camera, so to speak. As far as, if you had to pick which one, the dry form is probably the preferred form because it's usually slowly progressive and affects your vision slowly over time, where the wet is a lot more significant and it's a more sudden change. But there isn't really treatment for the dry form. So the wet form, basically it's called wet because new blood vessels will grow beneath the macula and can either leak blood or fluid into the macula. So that's why it's called wet. And so that usually is a little more severe. So it changes the vision faster. The potential for good detail is a lot less, a lot sooner. But there is treatment for the wet. So it's kind of almost like a catch-22 because the dry is less significant usually, but there's treatment for the wet. And so we have a picture here, I don't know if you can see with the light, but this is an actual photograph of the inside of the eye. The optic nerve here, all of the blood vessels that feed the retina come in with that optic nerve. And we don't have to look through muscle and skin to make veins look blue. So in the retina, the darker, thicker blood vessel is the vein. The lower, or smaller, narrower is the artery, but they both look red because we're looking right at them. This area here is the macula, so right off of the optic nerve is the macula, and the little kind of yellowish flecks in the picture are those deposits called drusen. This person's a visual acuity, which is our word for what they see as far as detail in the 20/20 lingo, is probably pretty good, like 20/20 average best. This person's probably seen 20/25 or 20/30, given there aren't any other eye conditions going on. So pretty good detail remaining with a picture that looks like this. This one is probably more acute, so really recent change to the macula with the wet form of macular degeneration. Again, optic nerve, all the blood vessels. This area right here is blood, and then it's really tough to see in the picture, but all the way around here is fluid. And this isn't drusen in the same way as the last picture. It's a deposit because of the fluid that's leaking into the retina. This person's ability to see detail when they look at something straight on is probably just enough to see a hand moving or maybe counting fingers. Is pretty significant here. And the reason I say this is probably a pretty recent onset picture is because as treatment goes on and time goes on, the body will take up that blood, and then we'll think, well, we get some better detail then. But really, it scars because the macula and the retina is such intricate tissue that even once the blood is gone, that doesn't come back. So I'd say that this is pretty new. So we don't want any of that happening, so what do we do to prevent that from happening? And still, even after all this time and research, there have been 2 long-term studies that have taken 10 years apiece to try and figure out nutrients and what we can do to formulate vitamin supplement or nutrition in order to prevent macular degeneration. And we still kind of have the same basics of They didn't really find a lot to reverse, more to prevent change from happening. And so we'll get back to those. But the big deal is protection from ultraviolet light is one of them. And in my new world of neuro rehab and how the brain functions, I kind of was going through this and I was like, ooh, but you need light. So everything in moderation, right? But typically as, you know, a community of people who maybe were outside quite a bit, I know, you know, growing up, grew up on a farm and we were always outside, no sunglasses, you know, maybe put a shirt on. You know, the tan was important and no sunscreen and those types of things. But we are outside a lot without protection from ultraviolet light. And so sometimes the incidence, just the exposure rate is higher because of, or incidence, excuse me, is higher because of the exposure to ultraviolet light. So hat and sunglasses and in moderation. Not smoking is a big risk factor. I have several conversations with patients about smoking. They usually will know. I'll say, well, you know, did you know that it was a big risk factor for macular degeneration? Because they know the risk factors for their heart. They know the risk factors for their lungs. But what they usually say is, no, I had no idea. And again, we don't have a lot to do to prevent macular degeneration. We don't have a lot to do to treat it. So that usually hits home with a lot of people as far as, boy, I really like to see in the detail in the center. I want to see pictures of my grandkids. Diet high in your green leafy vegetables. Again, we're going to go back to what you get from your nutrients. What it does for your overall health is important, and as we go forward, you know, there's going to be a resounding theme here. But what antioxidants do is we have what's in our body called free radicals from different environmental concerns, different things we ingest, those types of things. And free radicals, if they're left to be free, wreak havoc on your tissue in your body. So if you can give them something to bind them down, which are what antioxidants do, then they're not as much of a tendency to harm tissue. So that's what happens with your diet and your vegetables. If we don't get and can't get what we need from our diet, that's where the supplements come in. And so I should say too that I have no financial disclosures, is that what the word is? But I did put up a couple of the vitamin supplements that are based on the long-term studies over those 2 10-year studies as far as the amounts of beta-carotene, zinc, lutein, and zeaxanthin are kind of parts of those vitamin supplements that are geared toward eye health. And there are just a couple listed. I don't get paid by PreserVision to sell their product. But the lutein and the zeaxanthin, usually about a 40 milligram a day dose is important. And I have seen, one thing that I have coming up here is that most treatments don't reverse the effect of macular degeneration. In other words, you don't get your detail back necessarily. It just is geared toward keeping it from getting worse. But I have seen, this was several years ago, photos that we had sent a patient to the retinal specialist and photos of before they started the lutein, zeaxanthin, 40 milligrams a day dosing, and then a year later, and the picture of the retina had changed. The deposits were less, the pigment was less, and their detail got a little bit better. So never say never, I guess. But so again, treatment with or for macular degeneration typically doesn't reverse the effects. But it's important to, if there is change from macular degeneration, to see what you can do to maintain that level of vision. So the vitamins, supplements, keeping yourself overall healthy are one thing that we already talked about. If there is more significant, more the wet form where the fluid is leaking in, there are laser treatments, and that's been around for a while, where they use basically a laser to kind of seal up the leak, kind of like spot welding almost. Also injections. And what injections do, it's a medication because we can't just put it on the front surface of the eye because it doesn't get to the back where we need that medication to be. And what the medication is it's a factor to stop new blood vessel growth. And so without the new blood vessels growing, then they don't have as much of a tendency to leak the fluid in. Has anybody here had any injections for macular degeneration? Oh, that's good. But most of the time, and once you kind of get started on those, it seems pretty like, oh, geez, I have to go to the retinal specialist again. Once a month, I go to the retinal specialist because what that does is it gets that medicine, that factor that reduces the new blood vessel growth to the back of the eye where we need it, and that can really maintain vision. It's been a really big godsend over the last probably 10 years or so to maintain macular health once the wet form is there. I have had patients that, you know, in theory, hey, we're getting treatment, we should be getting better. And they get frustrated with once a month, going into the retinal specialist, a long appointment. And so I would encourage anybody that even knows anybody, it's frustrating to say, well, I'm not getting better. But patients who stop because they're not getting better detail or their vision isn't improving, they go south really fast and they lose a lot of vision really quickly if they're not maintaining that injection, that medication to the back. Any questions on macular degeneration? Yes?
Are there specialists like in the St. Cloud area that give those injections, or do you don't need to go to the cities?
Really good question. We have excellent retinal specialists in Sartell and St. Cloud. So St. Cloud they have a satellite clinic. They have several offices based in the metro, but they have a satellite clinic in St. Cloud right on Highway 15. And there's a practice in Sartell that has 2 retinal specialists as well. They're very busy people. They're usually long appointments, but I usually will tell my patients that, prepare for 3 or so hours, and it's not the appointment maybe that takes so long, but you have a lot of pictures and they do a lot of tests, and they're really busy people. But 3 or 4 hours to get to St. Cloud, have all that done, where you could be in the car that long. But they're really talented and really, we're really lucky to have them in central Minnesota. Thank you for that question. Anything? Yes?
What length of treatment is appropriate? I mean, once you start, if you live, say, 20 years with it, is treatment for the 20 years good?
For the wet form, yes. So that's why on the last slide I had up, sometimes indefinitely. Because kind of the conversation in care is, well, you want people to be able to use their vision for as long as they need it, which is as long as they're alive. Sometimes what will happen is the condition will kind of what they say we call burn out, and so once that is stable, then there's nothing really to seal up or calm down, then the retinal specialist will not continue treatment if there's nothing that can be done with that medication. Does that answer your question? Okay. Anything else? Okay, so moving on to cataracts, and you probably have heard about cataracts. My grandpa, when he had his coming on, he said, "Nisi, I think I have a Cadillac." And then we had bicycles in his bifocals too. So, but the cataract is, and I'll just go back to this slide. A cataract is a change to the lens inside. And so we have the very front surface, the colored part, and then the lens sits right behind the colored part. And what happens is light has to go all the way through the eye to the retina. That's where the receivers are for the light. And when this lens is nice and clear, the light goes straight to the back. When it's kind of cloudy or hazy, which is what happens with a cataract, it scatters. Okay, so instead of going straight to the back, the light hits the eye and it scatters. I kind of think about, so of course I look in through my side into eyes through cataracts all the time. But I kind of think about when I'm trying to feel like what the patient is experiencing from the inside out, like a warmer day, maybe like last Friday when it was really warm and the snow was melting and we're driving and all that splatter is coming up on the windshield. And if you're out of windshield washer fluid and your windshield is really dirty, you can see, but it's just kind of tough to see. That's kind of what I think about, like what it might look like from my side, or from the inside out, looking at a cataract. Like clean the windshield. Okay, so most often cataracts are just a normal change with age. There can be certain medications that can advance a cataract. There can be trauma that can advance a cataract. But for the most part, everybody, if they live long enough, will get a cataract eventually. Symptoms, so think about looking through that cloudy windshield and how that light would scatter through. So cloudy, kind of dim, blurry vision, difficulty with night driving, and of course, wintertime in Minnesota, it's dark a lot, so it might be 4 o'clock and it's getting kind of hard to drive. We can have sensitivity to light because of a lot of glare that happens. Just thinking about how the light is scattering through the eye, it induces a lot of glare. So halos around lights at night, just because we get a lot of that light scatter. Now, in the same token, might be like, well, geez, I'm sensitive to light, but I need more light when I'm reading. Okay, that increases the contrast and makes it a little easier to get that detail. Fading of the colors is usually so gradual that people don't even know that they're missing or what they're missing. I have a couple of stories about that. My mother-in-law was pretty sure after her cataract surgery that she needed new furniture, because once she had her cataracts out, she realized her recliners were plum color instead of brown. She, was pretty much thinking they were brown, but they were really plum. I had a different patient. She was a really fast talker, and I was having a hard time keeping up with her this day, but she was saying, geez, I have so much more time now that my cataracts are taken care of, and I didn't really understand that one, and I said, well, why do you have so much more time? And she said, well, I don't have to wash my white curtains all the time. They just look white and clean. I don't have to wash my curtains. So a lot of times that's what you will notice is, wow, colors are brighter, whites are whiter after you get your cataracts taken care of. So again, prevention of cataracts. Wearing sunglasses, here we go back to that ultraviolet light thing again. Usually a little bit earlier onset in some people who have higher exposures to ultraviolet light. But again, we need some. So, going forward, hat and sunglasses again. Just thinking about it doesn't burn your eyes, it's just kind of how your body processes that light energy. Healthy diet again. So again, fruits and vegetables give you your antioxidants, which help maintain the health of your eyes. Smoking. Again, here we go. But smoking, just maybe a little bit earlier onset again. I have my husband's really good friend he had his cataracts. He was in his 40s, really heavy smoker. I know of a couple other patients who have had cataracts early onset like that, but they were really heavy smokers most of the time. And we're kind of averaging, pending anything else different, the trauma or the medications, usually 70s, 80s, sometimes 60s, but usually that for the most part. So 40s pretty early. When we start to wonder about cataracts, patients will ask, well, do I have a cataract? And well, we can get you to see pretty good detail. And so it might be pretty mild, but as long as you can see the good detail and it's not affecting your life and lifestyle and driving at night and those types of symptoms, then we kind of just monitor. They're not really urgent. Once I get a patient who, we can change their glasses for a while, as long as they're seeing good detail and it's not a big change to adapt to the difference. Once they start to say, well, geez, I am having trouble driving at night, or I'm really being bothered by glare, those types of things, and I can't change the glasses prescription in order to increase the detail, that's when we talk more about cataract surgery. It used to be the case that cataract surgery was a little bit more complicated, involved procedure than it is now, and so cataracts had to be ripe. That was the word they, used. They have to be ripe before we can do cataract surgery. But now they've advanced the procedure so much that it's a lot lower risk, and so really when we start to notice a decline in vision and I can't make it better with glasses, then we talk a little bit more about cataract surgery. Because a lot of times, like say, I have a patient and their best corrected is like 20/40. Well, they're still legal to drive. Most other things you do, if you can be, driving down the road at that level of detail, you can probably see good enough. But you change the light, you change the environment, and that's when it can really decline with that glare as far as what level of detail you're capable of. So usually once we start to kind of say, well, you know, I'm not really seeing and I can't make it better, then it's ready, it's ripe enough. And cataract surgery is pretty straightforward, like I said. You go home the same day. The procedure itself is less than 10 minutes. Probably takes a lot longer to prep you and get you ready. I was in the room with my grandpa when he had his cataract surgery, and the surgeon told him he could sit up, he was done, and he said, "You're done already." He was gearing up for a little bit longer procedure, but it's pretty quick. Then no stitches, they use a really small incision, and then there's pressure inside the eye, so it just seals that up again. Even typically, day 1 after cataract surgery, I'll ask patients how their eyes feel. They'll say, well, it feels a little scratchy, almost word for word every time. And even though it's intentional trauma, it's trauma to the eye, and so with trauma to the body, we expect swelling and inflammation. So sometimes even early on, there's a little bit of blur because a swollen cornea, which is the part that swells, is kind of like looking through a whole roll of cellophane versus just one layer. As time goes on, the swelling goes down, and then you get a lot better detail that way. As you recover from cataract surgery, use some drops. I teach patients that, boy, you get really to be professional as that eye drops after cataract surgery. Because cataracts, the drops used after cataract surgery control inflammation, and then they prevent infection. So usually using drops, 2 or 3 bottles, usually for about a month. Not as consistently throughout the whole month, but at least that many during the first week. So typically after cataract surgery, you're seeing the first day after surgery, the first week after surgery, the first month after surgery, and then 3 months after surgery is kind of the typical post-operative schedule. More if you need it, but typically that's what we need. So after cataract surgery, if we go back to the picture again. So with cataract surgery, what happens is we take this lens out, the surgeon does, and then they put an implant lens in its place. Back probably 50 or more years ago by now, before they put that implant back in place, people who would have cataract surgery, they'd take the lens out and they didn't put that implant back in. They had really thick glasses then that make their eyes look really big. So they figured out how to replace that power. And so since the lens that we put in the eye has to have power to it anyway, why not take as much of your glasses prescription and put it in that implant? So a lot of times after cataract surgery, people will just need glasses to read. There are newer implants that correct astigmatism, newer implants that can correct the up-close reading too. It's a bifocal implant of some degree, but it's a little bit different than your bifocals in your glasses. But a lot of times you kind of get 2 for 1 when you get your cataracts taken out, because you get to remove the cataract and get rid of that, but then also you get the refractive procedure in order to clear up mostly the distance with that one. A lot of times patients will ask, do I get cataracts back after I've had cataract surgery? The answer is no. Sometimes what can happen is that lens inside sits in kind of like a little bag we call the lens capsule. And so we leave that intact when they do cataract surgery, and they put the implant lens in that capsule. And then what happens is the body says, I don't have a lens in there anymore. It doesn't recognize the silicone implant lens in the eye. And so it will say, I need to grow a new lens. Well, it's never going to catch up. So what happens is the cells end up depositing on that back surface of that lens capsule, and it ends up looking like a cataract again, because the light then scatters through those cells. And it seems a little fuzzy, a little hazy, like you're looking through that dirty windshield again. But we don't need cataract surgery again if that happens. They just use a laser to remove those cells. And that's a pretty straightforward, quick procedure as well, with almost immediate improvement in your vision. And usually once they do that procedure, it's a one-time kind of signal to the brain, says, okay, I don't need to make a new lens. So it's usually only done once, and then it gets the message that we don't need to do that again. Any questions on cataracts? Do we have any cataracts, patients who have had cataract surgery already? Yeah, you knew this stuff. Okay, So glaucoma is another eye condition that is usually a little bit more readily diagnosed as we age. Basically, you kind of think about just the cell division and what happens that way, and how long you're kind of around. But glaucoma is damage to the optic nerve fibers. So glaucoma, the optic nerve carries the information from your eyes to your brain. And glaucoma affects the outside vision first. So it affects the nerve fibers that give you the outside versus the center first. And it's usually pretty slowly progressive. And so if it was all at once or if it was in the center, we would know. The other thing about glaucoma is it doesn't hurt. You don't have any pain when those nerve fibers are dying off. And so one of the terms that is used to describe glaucoma is the silent thief of sight, because it gradually takes the outside and we don't know what's happening because it doesn't hurt. Good detail is maintained usually throughout glaucoma because that's the center. And so glaucoma affects the side, again, macular degeneration in the middle. Untreated glaucoma, end-stage glaucoma, gives you tunnel vision, or it can go completely dark or missing. I did a clinical rotation in a maximum security prison when I was still in school, and there was a 30-year-old with end-stage glaucoma that saw 20/20, and he really didn't know that he was missing his outside until we checked him out. Okay, so is it glaucoma or not? So I have patients who, we kind of go through, say, I'm suspicious, I need more information, and they kind of get a little frustrated because it's like, well, is it or isn't it? But I usually will say, we want it to be kind of a gray area, because if it's so obvious that you have glaucoma, that means you've lost vision already that you can't get back. And so we have to put a big puzzle together. And the pieces to the glaucoma puzzle are family history, which is usually now it's more thought of as your first generation, your siblings more so, because we know a whole lot more about glaucoma now than we used to. It used to be that if your pressure is inside your eyes, which is a risk factor as well, was over 20, then you had glaucoma. It did not matter if your optic nerve was healthy, never changing. If your pressures were over 20, you had glaucoma. If it wasn't, you didn't, which I have patients who have never had pressures higher than 12 that have glaucoma, and patients who have pressures of 30 that don't. So it really is an individual reading, so to speak, or expected normal. Ethnicity, African Americans, Hispanics, some of those populations have a little bit higher incidence of glaucoma. We're not off the hook. We have a little bit higher incidence of macular degeneration. Pigment is somewhat protective on that. The pressure inside is abbreviated IOP, so intraocular pressure, but that is considered the only controllable risk factor that we have. So when we're managing glaucoma, pressure is always talked about. The pressure inside the eye is always talked about because that's the one we can control. When I look at the optic nerve, I can see the very face of it as it enters the eye from the brain. And so everybody has a ratio within their optic nerve of where the nerve fibers are to where they're not. So that's one thing we look at in putting the puzzle together. Also the function. So there are other tests that test the function of the optic nerve, that can scan the thickness of the nerve fiber. So we have to really put all this puzzle pieces together. The thickness of the cornea can alter the pressure reading. So a really thick cornea can give a falsely high reading. A really thin cornea can give a falsely low reading. So that's factored in as well. And then other just history, as far as the case history, have we ever had a trauma? That can alter the mechanism of the outflow of the fluid inside the eye. Certain medications can affect the pressure inside as well. And again, kind of getting back to silent thief of sight, you can lose 40% of your visual field before you even realize it. More on the preventative side of things as far as the importance of eye exams, that's where this comes in. Most cases of glaucoma respond really well to treatment. And again, treatment most of the time is, we're just controlling that eye pressure. Again, the pressure inside the eye is kind of like checking the air in a tire. So what makes the pressure inside the eye is there's always fluid being produced and there's some draining out. And so what the medication does is either slows down the flow, so turns the faucet down, or works to open up the drain, so more drains out. And we have really good eye drops that are really safe, that are really effective. most of the time, the one, excuse me, that we use the most is once at night dosing, and it's really safe. You can get a little bit darker iris, so blue eyes might be a little bit more brown, but I haven't seen that happen yet. The other thing is longer and darker eyelashes, which most females really don't care about that side effect too much. But they work really well, and they work to lower that eye pressure. Thank you. Sometimes go ahead.
Can you have glaucoma and then be on the drops for a couple of years, and will that change to not having it?
No. If you're diagnosed with glaucoma and there's truly change from the optic nerve and the nerve fibers are dying off, the treatment affects the pressure inside, but it might slow the progression of glaucoma, but it doesn't stop or change that typically. Sometimes it can be, well, you had a pressure that was higher, or maybe we were thinking that, you were at risk for losing nerve fiber, which is what glaucoma is, and then we have more information that comes along, and maybe it was just that your pressure was high and your optic nerve is safe and nothing's changing, then sometimes we can take you off of medication as long as your optic nerve stays healthy. Does that make sense?
Must be what happened.
Yeah, and honestly, and that kind of goes back to, is it or isn't it? It's putting that big puzzle together, and we don't want to wait until you lose vision to take action, because that's the vision that you've already lost that you can't get back. So sometimes a conservative approach is warranted as well. Say there may be some other factors like in the family or those types of things, and then as we watch and we see that, no, your optic nerve is safe and nothing's changing, then sometimes we'll alter that. But the only way we know for truly, honestly, and truly if you have glaucoma or not is to see change over time, to have that optic nerve fiber die off. And that's the only way we really know what's working too. I mean, as far as what should my eye pressure be? That's kind of a loaded question because it's different for everybody. It's not like high blood pressure or what your blood pressure is, where 120/80 is pre-hypertension for everybody. Glaucoma, the pressure inside, again, it's really variable depending on the person, and it changes throughout the day. So usually it's a little higher in the morning, and then as you're upright more throughout the day, it goes down. And so we usually will try to, pinpoint, maybe check your pressure in the morning to see what that is, and then the next time check it in the afternoon to get a more comprehensive view on really where that's at. Sometimes you can, maybe I have a patient who they're consistently 15, 15, 15, which is kind of in the middle of an average normal range, and I check them one time and it's 30. Okay, well, that makes my ears perk up because a little over 20 is, usually more significant. And then I check them, several times after that and do the scans and do the tests and do the fields and never see any change other than it goes back to 15 all the time again. So we're trying to always look at that whole system and change over time. Sometimes with using drops is not, and that's how we administer the medication is through eye drops. Sometimes it's hard to remember to put drops in. Sometimes it's we don't have the dexterity to get the drops in. Sometimes I just had a patient now recently, she started reacting to the eye drops. She responded really well, it was keeping her pressure down, but she had an allergic reaction. So she is looking at a surgical procedure because she can't take the drops anymore. So some of those reasons, sometimes we get a little bit stubborn case that's not responding to the medication, and then we'll look at surgical options. And what surgical options do to lower the eye pressure is basically work to open up the drain to increase the outflow of that fluid inside the eye. Any other questions on glaucoma? Okay, excuse me. So dry eye syndrome might be, okay, big three: cataracts, glaucoma, macular degeneration. Okay, a lot of people don't really think about dry eyes, but it's really probably undiagnosed, left eye undiagnosed quite frequently, and is probably more common than we think. So what the tears do is each blink, tears spread across the front surface of the eye. And tears provide lubrication, they reduce risk of infection, they wash away the foreign matter and keep the surface of the eyes smooth and clear, which is important to seeing good detail. Because the cornea, if that's not a smooth surface, then you get a lot of that light scatter again through the eye, and that's when you have blur. So the difference kind of between blur from dry eyes and blur from like a cataract would be you can't blink away a cataract. Okay, so it's like, oh, it's blurry, but oh, blink, 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 it's better. Then that's usually a dry surface. And so basically, dry eyes can occur, and we'll get back to what causes dry eyes, but basically when the tear production and drainage is an imbalance. And it's a chronic condition. I had a patient recently who came in, crazy red eyes. Her skin around her eyes was all red. I mean, she was just inflamed. She looked so uncomfortable. We got her calmed down, improved that surface, and she asked me, well, how long do I have to use these eye drops? Or how long do I have to treat this? Because it really was just dry. And I said, well, you know, we're going to have to keep on this so it doesn't flare up and make you so uncomfortable again. So long term, again. There are a couple forms or arms of dry eye. One meaning we're just not producing enough tears, so the volume is decreased. The other one is where the front surface, where the tears, excuse me, are evaporating off the front surface more readily. Certain risk factors, again, age, certain medications. We can have mechanical reasons for dry eyes. My husband's uncle, every time I would see him, we lose a little bit of tension in our skin as we age, and his eyelids were really down away from the eye, the globe of the eye. So there's all this exposure always. Again, really red eyes. He had to have a procedure to kind of tighten up that skin so that he didn't have that exposure. So some of those mechanical types of things can happen too. The evaporative type of dry eye is basically we have 3 layers to the tears. There's a mucousy layer on the inside that holds the volume of the tears, which is watery, on the eye. And then there's an oily layer on the outside that keeps the watery layer from evaporating. And that oily layer is the layer that kind of breaks apart, and then the tears evaporate off the front surface pretty readily. Again, age, diet sometimes. In our, I don't know if you call it American diet, but we get a lot of omega-6s, which are pro-inflammatory, not as many omega-3s, which are anti-inflammatory. So you can be producing this oil that's more inflammatory versus protective, and that can contribute to dry eye symptoms as well. So what causes dry eye? How much time do you guys have today? Okay, so many factors come in. Age is one, of course, most of the time, you know, kind of everything dries out. Certain medications to keep your heart healthy, you might, you know, maybe be on a water pill to reduce fluid, well, that will dehydrate you. Certain types of medication for allergies. There are lots of classes of medication that can tend to dry you out. How much water you drink, how much caffeine you drink. So I had a little bit of caffeine this morning, and boy, I'm really getting kind of dry. Thanks for the water, Christine. But I can really feel it. Environment, you know, when it was so cold there for a couple weeks in a row, boy, I felt like we lived in the mountains. My eyes were dry, my mouth was dry. Wintertime here in Minnesota, that dry air can contribute. If you have underlying medical conditions, Mr. Arthur, the old itis guy, that's inflammation. Okay, inflammation gives you dryness, dryness gives you inflammation. It's this big cycle, okay? Even your skin in the wintertime gets pretty dry, gets red and cracked. That's inflammation. Again, underlying allergies. When your whole system is kind of fired up, it can contribute to dry eyes, and then sometimes we're taking medication, which contributes to dry eyes. Smoking again, and then one little one down at the bottom, which is kind of interesting. My cousin shared a link with me on Facebook, and she said, Denise, is this real? Because it was a microscopic view of this mite that lives in the eyelashes. It can happen. It's kind of disgusting to think about, but it causes inflammation on that surface. And there are kind of treatments that can be done just with over-the-counter, like tree oil and that sort of thing, but it definitely can contribute and is a little bit more common as we get older. Symptoms, well, it feels like there's something in there, like somebody threw a bunch of gravel in your eyes. They can burn, kind of just aggravating and irritating, just being aware that your eyes are there. And watering, and like I have on there, yes, watering. And I'll tell patients, and they'll say to me, you didn't hear me, doc. My eyes water, they're not dry, right? Okay, so what happens is when that front surface dries out, then the body will kick in what we call reflex tears. And reflex tears, kind of like those tears when you cut an onion and your eyes water, the problem with those tears is they come fast, they wash over, and they spill off. And so for me to make a recommendation for dry eyes to put drops in, I don't know, you're looking at me like I'm nuts, but it really works because you get that moisture back up on that front surface, and then the body doesn't have to kick in those reflex tears. And then blurry because, again, the front surface isn't uniform, so we get a lot of light scatter through the eye. So again, what do we do? Drops, usually first line. I was pretty excited recently because the dry eye treatment update. First line, still putting moisture in. So artificial tears, there are several formulations that work either against that volume of the tears or against the oily layer of the tears to keep that oily layer together better so that the tears aren't evaporating off that front surface as readily. And then we'll kind of go down and they'll come back up. But, you know, keeping hydrated. Have a extra glass of water instead of that extra cup of coffee. Avoiding smoking again, treating the eyelid. So if there is another condition, that's pretty common too, just from kind of the bacteria that's always on our skin everywhere. Sometimes what that puts off can gather in the eyelashes, and that can be aggravating to that front surface as well. So either that or with the mite situation, treating that eyelid and having that clear can also be helpful. Or like my uncle who had surgery to take that skin back up and put it closer to his eye itself. You know, environment, different, you know, making sure you have a humidifier going. Some of the nutritional supplements like fish oil, which give you your omega-3 fatty acids, which again reduce inflammation. So if that's the arm of dry eye that you have, that can really help sustain that and function of that tear film. Sometimes there are prescription eye drops, not even just the over-the-counter artificial tears. One you've probably heard of is called Restasis. That one's been around for a long time. And that works to kind of bump up the volume on the tears, reducing inflammation. There's a new one called Xiidra that has been really pretty successful as well. And most of the time, you know, just to work to make that front surface more uniform, usually at twice-a-day dosing. The problem with the prescription drops that turns a lot of people away is that a lot of times it's not on their insurance formularies, so it can be pretty expensive. And then conserving tears, kind of just going back up, we have, so the faucet's always on, and the tears either evaporate off the front surface or they drain out. And we have openings for the drain in our upper and lower eyelids, and then they come into a common channel and go into your nose and down your throat. So sometimes if you have eye drops, prescription eye drops, you can say, well, geez, they taste terrible. Like, well, I'm not drinking them, but they just follow your tears into the back of your throat. And so to bump up the volume again on that tears on that front surface, we can block the drain. And we usually would do that with first a temporary plug made out of collagen. Your body just takes it up again. Side effects to that would be, well, we plugged it up too much, now your eyes are watering. But if it's usually pretty well tolerated, then we can put a semi-permanent plug in made out of silicone. And again, that just bumps up the volume, plugs up the drain. And we have two openings and they evaporate. So usually we would plug up the bottom opening first because of gravity. Most of your tears drain out through that channel. So we still have capillary action up through the top and then evaporation. So it's pretty rare once we get to the dry eye point of treatment to have, you know, plugged it up too much.
Before you go to that,
Yeah, go ahead.
I must have the watery dry eyes
Mm-hmm.
because what happens several times a day, I get real crusty
Mm-hmm.
in here, and I have to always be careful to wash them out so people don't think I didn't wash my eyes.
Yeah.
You know, so is that what that is?
It can
I
be.
mean, so you talk about it draining back through your nose, but can it drain out across your
Right.
outside of your nose?
Yep. Mm-hmm. Mm-hmm. Yep, and if you think about too, the consistency of the tears, that oily layer, if you're producing more of an inflammatory oily layer, it can kind of, the consistency kind of breaks down almost to like soap. And so it can just kind of be what's generated from that are those little crusties. And that's really
So it's
how.
not the pink eye stuff. It's just like
No.
salt.
Yeah, yeah. So it's just the composition, I would say, of the oils in your tears that's breaking down. Mm-hmm. Anybody else? Any questions? Pretty common, pretty common. Sometimes I'll think, you know, you almost don't know how bad it is until it's better. Like, oh, I didn't know my eyes were supposed to feel that good. And then just touching on things that can happen to the retina. Basically, all of these conditions, just kind of putting the plug in for regular eye exams too. People will say, well, I see fine, you know, that we're good. But it's more preventative for the most part. So the retina, again, is the lining on the inside of the eye. And so when you have any conditions going on, so high blood pressure and diabetes are very common, of course, it can affect the rest of you. And so sometimes I'll have patients filling out their health history forms like, why do I have to do it? Why do you have to know that I'm on high blood pressure? You're just going to give me glasses. Well, your eyes are connected, and so they need blood supply as well. And sometimes the first place we can see change anywhere in the body, especially with diabetes, is in the retina. So looking in the back again. So retinopathy is damage to that retina and the retinal circulation. Basically, it gets deprived of oxygen. Frequently, we can have an effect from systemic conditions. Very recently, we had the solar eclipse, and they had protective glasses that were given out to protect the retina from solar radiation. Sometimes trauma. Otherwise, we can have occlusive disease as well. And really, with diabetes, you know, patients will say, well, my doctor told me I had to come in. They asked me every time. They told me I had to come in, that's why I'm here. And I said, did they ever tell you why? Well, because the retina there's such a large part of the retina that's not the center, that's not the detail. So unless you have a big change, or it's right at the macula, you might not notice it in your vision. And diabetic retinopathy is the leading cause of preventable blindness in the United States. So being more on top of that is, again, coming in and getting your eyes checked and being more preventative. Symptoms, you might not notice it. Sometimes in an extreme case, if there's blood leaking into the space in front of the retina, you can have floaters, strings and spots in your vision. Sometimes it can be one area is affected, so there may be blood in the retina. Patients like, well, I can see you, but not the top half of you when I look at you. Sometimes that's more significant as far as the darker, empty parts of your vision. Just quickly here, non-proliferative is kind of the early part. Mm-hmm.
Can you explain a little bit more about floaters?
Sure. So in this case, floaters are more because there's fluid or blood leaking into the space in front of the retina. Go back to my diagram here from the side. I think. Ooh, there we go. Okay, so the retina again lines the inside. We have the lens inside. This space right in here is a gel-like substance. It's clear. And as we get older, it tends to become less like a gel, more like a liquid, and it will condense against the structure of that gel, which is really stringy. And so for lack of a better term, it kind of clumps together. And the light has to go all the way through the eye, again, through that space to the retina. That's where the receivers are for the light. And so a kind of benign, typical floater is just that gel, that condensed area of gel. So the light goes through, hits that condensed area of gel and casts a shadow on your retina. And that's what you see as your floater when it's not related to like blood in that space. Very common because that gel just changes. It kind of goes with how old you are. So I'll be 42 here coming up, and so I have a 42% chance of that gel already changing and pulling away from that retina. At 80, I have an 80% chance of that happening. Mm-hmm.
And then they disappear, so what happens when they disappear? What's going on?
Good question, too. What happens to those floaters? They don't go away, but right here, if we put a line here, straight back to the macula, that's called the visual axis. And so when that clump, like I said, for lack of a better term, is right here, then you notice that floater. Well, gravity helps us out a little bit, and what happens is that condensed area of gel kind of settles into the lower part of the eye, and so you just don't notice it as readily because it's not in that visual axis, unless you move your eye just right, and then it kind of almost like shaking up a snow globe, and then it'll disperse that, and you'll see those floaters. Any other questions on that? Okay, thank you. So on the difference, though, when you have some vascular conditions, it's, you notice those floaters. It usually isn't related to blood in that space, but it's not a half bad idea to get it checked out. The proliferative kind is more just when we're just to the point where, boy, we're not getting oxygen. So oxygen to tissue is the big deal. And if, so in the cases of like high blood pressure or occlusive disease, you're not getting oxygen to the tissue just because it can't get there. With diabetes, what happens when the blood sugar is high is the red blood cells are the carriers for oxygen to tissue, and they are not as good at doing that job when your blood sugar is high. So that's how oxygen can be deprived with diabetes. And what happens when tissue doesn't get oxygen, body says, I need some blood vessels, and it'll start to grow new blood vessels into that tissue. And new blood vessels are leaky, they're weak, and they're fragile, they'll break. So on the left, this is the non-proliferative, and you can just see some deposits again, some fluid, some blood. It's pretty tough to tell, but these little squiggly blood vessels are all new blood vessels. This is the worst kind, and this is actually the retina pulling away in a detachment, and there's a big break, and there's a big hemorrhage here. These two really significant forms of retinopathy. Typically, they need a laser basically to kill off the retina. Yes?
When you say high blood pressure, does that mean uncontrolled, or does it mean you're taking meds and it's controlled?
Well, we're more at risk if it's not controlled, but still can happen even if controlled. And that's a really good question because, even if it's controlled, even with diabetes or high blood pressure, physicians will sometimes, especially with diabetes, make the recommendation to come in and get your eyes checked. But I'll usually tell patients, unless it happens right at the macula, if there's a change, or it's really big, you're not going to notice it. But if I notice it, it's easier to get you back to your physician to get a little bit tighter control on that blood pressure before it affects, because those blood vessels in the retina are really tiny. They're really small caliber. And so there we go, that's treatment. Big one, manage the condition, okay? Get you back to your doc and they say, well, we see changes to the retinal blood vessels. Let's get a little tighter control. We need that blood pressure a little lower, or we need the blood sugar more controlled. Again, the same medication that's used for the wet form of macular degeneration can stop the new blood vessel growth. That's used commonly in retinopathy with high blood pressure or diabetes. Again, a laser treatment to kind of seal up those blood vessels, or in a more severe, on that right-sided picture with the break in the retina and the big hemorrhage, then they basically use a laser to kill off retina so the demand on the oxygen isn't as high. That word at the bottom is basically taking the gel out and putting a new gel in. So there you go, there you come next.